let's start again. It's my great
You're
pleasure
fine.
to introduce Dr. Carlos Del Rio, Distinguished Professor of Medicine at Emory University, and also the co-director of the Center for AIDS Research at Emory University, as well as a professor in the Rollins School of Public Health. And he's going to be talking to us about long-term complications from COVID-19. So thank you very much, Carlos, for being here.
Thank you, Susan and Paul, for the invitation. And I really like Christine's talk. So the first thing I'm going to ask everybody to do is to get up from their chair. You got to do this 10 minutes a day. So get 10 times a day. So sit down and stretch a little bit. Because I'm really worried that with Zoom meetings all day, we're just not getting up and walking around as much as we should, and that's not good. So I'm going to talk about chronic long COVID, and let me just start by saying that this is a fairly new topic, so there's a lot of questions and not many answers. And I have no conflict of interest related to this activity. I'm hoping to describe the long-term health consequences of COVID, to distinguish post-acute COVID from chronic COVID, and to monitor and to help you think about monitoring the health impacts of COVID in your patients. And I'll start by this quote. Paul Gardner, who's a professor of epidemiology at the London School of Tropical Medicine, wrote on the 95th day after the onset of symptoms, "I'm unable to be out of bed for more than 3 hours at a stretch. My arms and legs are permanently fizzing as if injected with Szechuan peppercorns. I have ringing in the ears, intermittent brain fog, palpitations, and dramatic mood swings." And I think this was one of the first descriptions of what we now know as chronic long COVID that really is beginning to think about the syndrome. After that, there was this article by Ed Young in The Atlantic talking about redefining what this is. And then Nature had this article about saying, people months after COVID still battling the symptoms. And then, talking about this and growing numbers of people being long haulers of stump stumpers. So the first issue is, what is this? And as epidemiologists, we like to have definitions. And I think it's pretty clear that clinicians have observed prolonged sequelae of acute COVID, either persistence of severe symptoms or substantial organ damage. But there has really not been a consensus definition of this. And as you saw, the terms long COVID or long haulers were used. And I'll tell you a funny story. When I first suggested to the editor of JAMA that I write a viewpoint on long haulers, on COVID long haulers, he initially thought I was talking about COVID among truck drivers. He didn't quite understand what I was talking about until I explained to him what it was. So one of the best data comes actually from this COVID symptom study. And this is an app-based study in which over 4,000 people in the US and UK and Sweden have entered symptoms. And as you can see now, data suggests that about 10 to 50% of individuals with COVID, even mild cases, do not recover quickly, if you look at this data. And I showed you a map there in Georgia where you can actually get down and really get an idea of who's entering data. This study from CDC was actually very good because this was a telephone survey, a random sample of 292 adults who had tested COVID positive, SARS-CoV positive at PCR, and who were outpatients. And I mentioned this being outpatients because there's a lot of question about, are these symptoms a result of being in the hospital, being in the ICU? So these were all outpatients or ED visits. And they interviewed them a median of 16 days after onset of symptoms. And in 35% of those individuals, with a median age of 42.5 years, of which 52% were female, 32% had not returned to the usual state of health. And I think that's a really important thing to know, that 1 in 5 adults, previously healthy adults, were not back to the usual health 2 to 3 weeks after testing positive for COVID. So this persistence of symptoms occurs regardless of age, comorbid burden, degree of COVID severity of illness. One of the first studies that came out was actually this one from Italy, talking about persistent symptoms. So they looked at 145 patients who had been hospitalized in Italy with a median age of 56, and 12% had been in the ICU. And what they saw is fatigue, dyspnea, joint pains were common symptoms. But only 18% of individuals, only 12% of the individuals, 18 individuals, had no symptoms. The great majority had one or more symptoms, and you can see that three or more symptoms were present in almost half of them. And in many of them, this was actually impacting their quality of life. This study from France similarly looked at and tried to show that there's no difference between people in the wards and people in the ICU. Again, a telephone survey of 120 hospitalized patients with a median follow-up of 110 days, median age of 63, 75% male, and the most frequent symptoms were fatigue, dyspnea, loss of memory. And again, without not much difference between being in the ICU and being in the wards, even though you can see there that there is some differences. People who were in the ward had maybe some other symptoms, more depression compared to people who were in the ICU, who had more discomfort and inability to recover their usual activities. And looking at who survives after ICU stays, in this study, what they looked at is that physical impairments, primarily joint contractures and muscle wasting, upper extremity sequelae as a result of moving, from supine to prone positions, and diaphragmatic dysfunction as well as laryngeal injury were common from intubation. But they were also cognitive and mental health impairments, as well as barriers to meaningful life. I'm not going to spend a lot of time on neurological manifestations. We'll have a talk after this on neurological manifestations, but this brain fog, heart damage are really lingering impacts that are beginning to alarm many of us. So this is some of the proposed definitions that exist out there. The first one is that of a post-acute COVID. And we call post-acute COVID this persistence of symptoms extending beyond 3 weeks after initial symptoms. And then chronic COVID as persistent symptoms extending beyond 12 weeks after initial symptoms. And you can see there's some rationale for that and some ways to think about it. So CDC at ID Week presented this abstract that tries to define the syndrome, right? You have acute infection that we all understand. You have post-acute hyperinflammatory illnesses, and then you have the late sequelae. And when you look at the numbers, when they presented this, there were only 8.5 million cases in the U.S. Now we're close to 26 million cases in the U.S. But think about even if 10% of people develop late sequelae, if you're close to 30 million Americans, you're talking about 3 million people that are going to have this chronic sequela, chronic syndrome of COVID. So I'm going to talk a little bit about the neurological, cardiovascular, and renal manifestations. So what happens at the level of the heart? Well, at the level of the heart, primarily myocarditis and ventricular arrhythmias are the common manifestations. The pathogenesis could be direct invasion by the virus, inflammation, and it's probably thought to be blunting of the ACE2 receptors that does this. And I think the big question is, will this lead to heart failure as a result in the future? So here's one study. In this one study, they did cardiac tissue from 39 consecutive autopsy cases, and they could document the presence of the virus in 61% of those. And if the viral load was above 1,000, you can even see more. And the cytokine response was thought to play an important part. And when they compared 15 patients without cardiac dysfunction with patients with more than 1,000 copies, they showed that no inflammatory cells infiltrates or difference in leukocyte numbers for high power fields. Here's a study from Germany, 100 patients in which they performed cardiac MRIs, and there was cardiac involvement in 78% of patients, and evidence of ongoing myocardial inflammation. So this suggests that there is ongoing myocardial damaging as a result of COVID. Unfortunately, this was not a randomized sample, so they may be biased towards those that have cardiac findings. And finally, there's this other study showing in young adults, these are competitive athletes, who none had been hospitalized with COVID, but 46% had evidence of myocarditis or prior myocardial injury by cardiac MRI that was performed after they had a positive test. So persistent cardiac abnormalities identify not only the elderly, but also in those who are young. How about the lungs? Well, chronic cough, fibrotic lung disease, bronchiectasis, and pulmonary vascular diseases are important manifestations. And the pathogenesis here is probably an inflammatory response. And again, I'm reminding that the lung only knows one way to heal, and that is fibrosis. So they have a lot of damage to the lung, you'll have fibrosis. And I've heard now of several patients that require lung transplantation after severe COVID. There's also, of course, the issue of thromboembolic disease, who may be complicating the process. But are we going to see an increase in COPD as a result? Are we going to see an increase in pulmonary fibrosis as a result? This is one interesting study in which they looked at what were the sequelae at the level of the lung. And obviously, the acute manifestations, we know about them. They're pneumonia, ARDS, and hypoxic respiratory failure. But post-acute manifestations included primarily a decrease in DLCO. This is diffusive capacity of carbon monoxide. And 49% also having diminished respiratory muscle strength. And if you follow them 3 months after the diagnosis, you still have 75% with decreased DLCO and 71% with radiographic evidence of increased thickening and fibrosis. So when you think about the lung sequelae and you compound them with the cardiovascular comorbidity, I think you can begin to see that there could be a persistent decline in pulmonary function and cardiac function that could have significant consequences. Again, I'm not going to spend a lot of time on the brain. There will be a talk dedicated to the brain, but obviously this is a very troubling area that we're all very concerned about. How about the kidney? Well, acutely we see renal failure, but you can also see proteinuria, and there is inflammation. There's direct viral invasion of the kidney cells with infection of the ACE2 receptors. And will there be a long-term need for chronic renal replacement therapy in patients with post-COVID? Does COVID cause diabetes? Well, we know that diabetes is associated with an increased risk of severe COVID, but new onset diabetes, including UK and hyperosmolar coma, have been observed now in patients with COVID. And there's ACE2 receptors present in the pancreatic island cells. So there's likely a diabetogenic effect of COVID-19. And in fact, there's a COVID DAB project that is a registry project that is actually looking at this and trying to develop more data on whether COVID and diabetes are related in a bidirectional way. And there appears to be more recent data suggesting that indeed is the case. Finally, I want to talk about emotional health and well-being. Are we at risk of a global mental health and behavioral crisis, given the sheer number of COVID patients? And I think, it's not just COVID, but it's a syndrome of isolation, of fatigue, of stigma, and all those things of the financial losses that people are having that could all have significant consequences for patients. And it's because the diagnosis of COVID and the subsequent need for physical distancing has been associated with feelings of isolation and loneliness. COVID-related stigma has become pervasive and can result in a sense of helplessness. There's also an increased report of lingering malaise and exhaustion, very similar to chronic fatigue syndrome, that gets patients to a degree of physical disability and emotional disturbance. And finally, individuals recovering from COVID are at greater risk of depression, anxiety, PTSD, and substance use disorders. So as you can see from this article published in Lancet Infectious Disease, there's a long list of research needs around COVID, long COVID. And in fact, the NIH has recently put a group together precisely to start develop a research agenda into how better explain and understand the syndrome, but also to look at potential therapies that we may utilize in the not too distant future. As I said, together with Pri Milani, Lauren Collins, and I wrote this piece a couple of months ago for JAMA, talking about the long-term health consequences of COVID. And we really think that you need long-range longitudinal observational studies and clinical trials to elucidate this health consequence attributable to COVID and how does it compare to other serious illness. And it begins to remind me of what we did in HIV early in the HIV epidemic when we established the MAX cohort, the multi-center AIDS cohort study in which, MSMs with and without HIV were followed, and a lot of good data out of the long-term consequences of HIV has actually come out of those studies. So those cohort studies are probably going to be part of what the NIH does in the not-too-distant future. So in conclusion, acute COVID symptomatic adults, about 35% do not return to the usual state of health 2 to 3 weeks after testing. And among persons aged 18 to 34 with no chronic medical conditions, 1 in 5 have not returned to the usual state of health after COVID. If patients have recovered from COVID, 87.4% report persistence of at least one symptom, in particular fatigue and dyspnea. And 78% of patients in an observational cohort have recovered from COVID had cardiac MRI findings suggested cardiac involvement, and in 60% there's ongoing myocardial inflammation. And finally, 1/3 of patients recovering from COVID report lingering neurological and psychological manifestations. So likely large number of patients will experience long-term sequelae of COVID. Outpatient post-COVID clinics are opening in many localities where large outbreaks have occurred and take care of these patients. But it is imperative that the care of this vulnerable population take a multidisciplinary approach. And I think there's something we've developed in HIV, this multidisciplinary approaches that really transform therapy. And I think there's a lot to be said in a similar way for COVID. And where we can integrate a thoughtful research agenda into the care and avoid health system fragmentation as a way to do a comprehensive study of the long-term consequences of COVID and the multiple organ system and long-term dysfunction. And this will be an opportunity to effectively and systematically conduct studies of therapeutic interventions that will help to mitigate the adverse physical and mental health effects of hundreds, if not thousands, or not even millions of people who are going to recover from COVID and who are going to have significant impairments and long-term consequences. And with that, Susan, I'll end and happy to answer any questions.
Thanks so much, Carlos. That was a fantastic overview of a very challenging topic. We have a number of questions that have come in. The first is, what do we know about COVID long-term complications in children, if anything?
We don't know a lot. As I said, if you go to that slide that CDC developed of the syndrome, they put, we know the kids develop some of the kids develop this inflammatory syndrome, hyperimmune inflammatory syndrome, but we don't really know. There's not enough data to look at long-term consequences, and obviously something that needs to be done. In my mind, from talking to colleagues, I think one of the most important long-term consequences of COVID in children, and is not only of having COVID, but the COVID situation is the mental health consequences and depression and isolation and other mental health consequences that we're going to have to pay attention to.
One person asked if the individuals with long-term consequences might have persistent viremia in some hidden reservoirs, or if it really is felt that they've cleared the virus, but they have these long-term consequences persisting despite lack of viremia.
I think there's no viremia present. There's this lack of viremia. This is the virus could have caused infection in the heart and caused inflammation, but then the virus dies, and it's the inflammatory component that is causing the damage. So it's a combination of inflammation and healing that then leads to the problem, like in the lungs, fibrosis. Different from HIV, in which you have a chronic persistent viral infection. That's not the case in COVID.
Yeah. Can you speak at all to therapeutic interventions for symptomatic patients? Do we have much available to us at this point? And
we don't, and that's what is part of the NIH research agenda, is to develop a research agenda of what are the kind of therapeutic interventions. And as you know, from Lyme and chronic fatigue and a lot of those syndromes, I think the research agenda was not well developed, and we sort of suffered from that. So I think it's going to be really important that a thoughtful research agenda be developed here, so when you look at different interventions, you can see what happens.
Yeah. One person asked if there was persistent muscle weakness that's separate from hospitalization and ICU attributable weakness. Is there?
Yeah, there is. And that I think is what's interesting, right? We all know about this post-ICU syndrome that people develop, but this is different. This patients complain of a muscle fatigue, and as I said from the description that vignette that I read from Paul Garner, he talks about this feeling his muscles like being injected, like almost having burning inside the muscle.
One person was asking if there's any molecular mimicry at play that you might be concerned about with the mRNA preventive strategies. And I guess the question is, do we know anything about breakthrough infections in vaccinees? They're so infrequent at this point, but whether or not those prevent long-term sequelae of COVID.
No, that's a really good consequence. We don't, and obviously all of us working in vaccines are really interested in seeing, does the vaccine really prevent infection? Because, we have all been concerned that if you develop infection on a vaccine, you may not develop symptoms, but you can still develop long-term sequelae. And I think that's one of the concerns that everybody has.
Yeah.
And I think those are really important questions to answer going forward. And that's why CDC is incredibly interested in trying to understand who goes on, who has documented, if you have well-documented infection after 2 doses of vaccine and several weeks gone by, a true vaccine failure, to really look at those strains and look at those individuals very carefully.
There were questions about whether you actually require a SARS-CoV-2 documented diagnosis in order to diagnose this long-term syndrome, and if all of the attention that's being paid in the media might lead people to have increased reporting of symptoms. Do you have any thoughts about that?
No, I don't. But I would tell you, the syndrome is real. I've seen it. And yes, I guess what could happen is, let's suppose somebody shows up in clinic and is fatigued and is tired, this, that, and the other. I think the problem that I can see having is you can say, well, this person could have chronic post long COVID syndrome, chronic COVID. So then you wouldn't be able to test them with PCR because your virus is long gone, but you've got a serology, and the serology is going to be positive. And I think you may attribute the syndrome to COVID when, in fact, the reason for the fatigue could be the patient has cancer or something else. And I worry that there may be a combination of either overdiagnosis or misdiagnosis, because we're going to be using serology. There's going to be so many people with past infection that don't have this, that I think there's going to be a lot of anchoring bias going on.
And conversely, are there recommended screening tests that you would recommend for people, for COVID survivors, like echoes, chest x-rays, PFTs, those sorts of things?
At this point in time, if there's no symptoms, I'm not recommending that people do that. But, when I recently saw a patient that had clearly, continuous tachycardia and cannot go up the stairs like he used to, and he's like 12 weeks, the first 13, 14 weeks out. I did recommend that he get an echo and he get a cardiac MRI. Yeah.
There were some questions about how we might study this in healthy athletes in particular, that what you raised about the really shocking numbers of healthy athletes who had cardiac complications. Does that fit into your research agenda that you're recommending?
Yeah, I think there's a lot of interest in this, and obviously through the NCAA, that I've been working with the NCAA and colleges and looking at sports athletes, there's a lot of interest in looking at this, because obviously there's a lot of concern about, having a young athlete, healthy individuals develop COVID and then not being able to continue, playing or doing whatever they were doing.
Mm-hmm. Someone asked if there were persistent symptoms of elevated inflammatory indicators or persistent microvascular hypercoagulopathy that may be some of the underlying etiology of some of these complications.
Yeah, that's being looked at. I think the data that I've seen so far is not conclusive.
So, Carlos, if you were going to develop a research agenda around this COVID long haul syndrome, what would that look like? Can you lay out for us what the components of such a research agenda might be?
I think it'll be really important to establish cohort studies, to establish a series of sort of routine ways in which you're going to evaluate those patients, in which you make sure you include participants that are both young and old, that are both asymptomatic and hospitalized. And then you develop a standardized way, like we've done in HIV, right? Standardized testing, regular testing of, CTs or MRIs or cardiac MRIs, echoes, etc. And you establish, and then you develop you look at inflammatory markers, and you look at and you probably store some cells to see what in the future may come up. But I think cohorts are going to be the answer here in trying to really define the syndrome, as opposed to just make it, once kind of an impression.
Uh-huh. I guess there was just some discussion about how the intersection between long haulers and impacts on frailty. And if you think that it was kind of a natural progression from this discussion of frailty.
It could really be, I mean, again, a lot of older individuals that I've seen, and many of you may have seen, older individuals go to the ICU or get COVID, and then they just never recover. They go on to have a significant frailty syndrome that then, keeps on returning them to the hospital with other problems.
Okay. So one person asked about use of all kinds of other agents that are being tried because people get desperate. Ivermectin, Wellbutrin, colchicine, aspirin. Is there anything that you recommend at this point for long haul syndrome, or is it really just needs to be part of the research agenda?
I think it needs to be a part of the research agenda. I think at this point in time, I don't think there's evidence of any of that being abused.
And has there been any evidence that monoclonal antibodies have any impact on the long-term outcomes?
Good question. I haven't looked at that. That's a really good question. I haven't looked at it.
So are there predisposing conditions that seem to increase the risk of long-term COVID? You made the case that people don't necessarily have to have a lot of comorbidity.
Not really. It could be young, could be old. I really haven't seen anything that clearly says that.
And are there any phenotypes in particular, or is it just really any? You may get any combination of these long-term.
I think it's pretty much any phenotype. I mean, I've seen people who are previously healthy not do well, and then the opposite, right?
Yeah. And any sense of just how long this lasts, and if there are sort of indications of when?
Well, I mean, clearly it's not chronic forever. I mean, we've seen some people develop this and eventually go on to recover. But the question is, how long will it last? We don't know because we haven't seen this long enough, right? And
are we seeing any different patterns globally? This is being reported elsewhere in the world?
We've seen it in China. Has some reports that I'm looking at. There's a recent report from China that looked at long COVID. So I think we're seeing it everywhere.
And no differences in the patterns?
No, it looks pretty similar.
Okay. Well, this has been a really interesting presentation. It's one that raises all kinds of challenges and questions, and it sounds like there really does need to be a very robust research agenda to address this. It does tie into what our next presentation is going to be about. You did get a lot of compliments on terrific talk, and so what I'm going to do now is turn it over to Paul to move on to our final presentation.
Okay.
Thank you.